Welcome to webinar number 6 in our AFBSS webinar series. Today's webinar is a panel-style discussion where we'll be going over client engagement and navigation services for those that are unhoused. And now, without further ado, I'd like to pass it over to our presenters, Charles Robbins and Rachel Johnson-Yates.
Again, thanks for joining us. My name is Charles Robbins. I'm a principal with Health Management Associates. I come from the community-based organization sector, working in numerous local and national organizations, including the Trevor Project and AIDS Project Los Angeles and the Village Family Services. I've been at HMA for 8 years, and my portfolio of work primarily has been around behavioral health and public health. And it's just a delight to be with you all. I'm also acting as the co-project director for this particular initiative on behalf of DHCS. And with that, I'm going to turn it over to my colleague, Rachel.
Hi, everyone. I'm so happy to be here with you today. My name's Rachel. I am an associate principal. I've been with HMA 3.5 years. Prior to that, I was the Deputy Commissioner, Chief of Staff for Indiana's Division of Mental Health and Addiction, and have a long history of doing work to help address the needs of people with co-occurring mental health and SUD needs, including folks who have housing instability and who are unhoused, and just really thankful to help promote this initiative and this work in California. Thanks, Charles.
Awesome. All right, let's go to the next slide. So our agenda today, I'm going to do a little bit of level setting for assertive field-based initiation of SUD treatment and services. Then we're going to have our panel discussion. We've got some great panelists, and we'll have those introductions. And then at the end, we will have open Q&A time. All right, let's get to it. Next. So we've got some learning objectives. We want you to walk away being able to identify evidence-based field-tested strategies for engaging and supporting individuals who are unhoused through outreach and related services. Be able to describe practical approaches used by frontline providers to address common challenges encountered in field-based support work. And finally, be able to apply insights from panelists to inform participants' own outreach, service delivery, or program development efforts through discussion and Q&A. Next. So what is assertive field-based? Let's go to the next slide. This is just, you may have attended the very first webinar. These are some repeat slides from that. But this all falls under Proposition 1, which our California voters approved. And it authorized a very significant bond, which is focused on behavioral health infrastructure. And it amended the Mental Health Service Act by renaming it the Behavioral Health Services Act. And it modifies how those funds are allocated. There are some changes in eligible population and some changes to oversight accountability, as well as the community planning process. Next slide. So the goal of the Behavioral Health Service Act, its purpose is to reform, modernize, and expand the Mental Health Service Act to address homelessness, substance use disorder, and systemic gaps. This was a big shift. And then some core goals: improve access to integrated behavioral health care, expand housing interventions, and enhance transparency and equity in outcomes. Next. As part of the funding, there are 3 buckets, and assertive field-based services falls under full service partnerships, which is 35% of the budget. Behavioral health services are an additional 35%, and then housing interventions are at 30%. So FSP programs provide that individualized team-based care to individuals living with significant behavioral health needs. And it has that whatever it takes approach. This is the old wraparound philosophy. And some of these key features are, I've mentioned the funding. They must make the full FSP continuum available, which is outlined by the Department of healthcare services. There is this integration of SUD treatment, very exciting, and also includes the initiation of assertive field-based SUD services, which is why we are here. Next. Our assertive field-based services provide, and what HMA is doing is we're providing technical assistance to support counties in the implementation of these services. And what we recognize is that there needs to be more proactive strategies to engage, prevent overdose, and improve access to MAT. And what's really important to note is that our training and technical assistance includes all SUDs, not just opioid use disorder. And counties are being required to deploy assertive field-based initiation programs as part of their integrated plan, which is being submitted for July, and it's a 3-year plan. Next. So I mentioned that it has a no wrong door approach, and we have been. There are 3 areas that are really important for you to know about, and that's an upcoming slide. Counties are encouraged to identify the populations, including people who are unhoused or housing insecure, justice involved, and individuals with co-occurring mental health needs. And it requires counties to conduct ongoing targeted outreach to engage and initiate individuals living with SUD into MAT and any community-based and low barrier setting. Next. So those low barrier settings include the street, shelters, homeless encampments, consumer-operated wellness centers, drop-in centers, syringe service programs, medication and mobile narcotic treatment programs, and other easily accessed locations to reach people where they are. Next. So that gives you a sense of the requirements. There are 3 specific areas that counties need to stand up at least one initiative, and that's data-informed targeted outreach. So really using data to figure out where should we spend our time doing outreach efforts. So, and then to provide mobile field-based programs and to offer open access clinics. Those are the 3 areas in which counties need to at least lift one initiative or have one initiative already in place. Next. And with that, we're going to bring our panelists on board and do some introductions, and then we've got some questions for them. So let's go to the next slide. And if we can spotlight our panelists. Terrific. I'm going to ask our panelists to do some self-introductions. So I'm going to turn it over to Brett.
All right. Thank you very much. I'm Brett. I'm the director for street medicine at USC and vice chair of the International Street Medicine Institute. I've been practicing street medicine for 20 years, and also my role at the Institute is to help train and begin new programs, and have started or expanded over 200 since I began.
Katie.
Hi, everybody. My name is Katie Quijada. I am a employee of California Bridge, working as the navigator for the California Bridge Connect program, which I'll tell you more about in a little bit. But I am a former substance use navigator, providing navigation services to folks in the emergency department of UC Irvine Medical Center. And prior to that, I was a community health worker working in a syringe service program alongside a street medicine team at UCLA.
Awesome. Thank you. And Shai.
Hey everyone, I'm Cheyenne Rabb. Everyone calls me Shy. I am the Chief of Psychiatry at the Los Angeles County Department of Mental Health, specifically the Chief of Psychiatry over county-wide engagement and field-based services. I've been with the Department of Mental Health at LA County for most of my professional career. The past is going to be almost 10 years now. I've practiced psychiatry in almost every type of setting that DMH has to offer, but more recently, starting in 2020 around COVID is when I began providing street psychiatry services for the Department of Mental Health. And created the workflows that are used by most DMH teams now, where street psychiatry is being practiced. So that's an expert level of expertise that I'll be bringing to this panel. And I don't think it was mentioned earlier, but I do not have any financial disclosures to report. As much as I would like to have them, I do not. Financial
Thank you.
disclosures, my
Appreciate
student
that.
loans.
You're open to them.
Right. All right. Thank you. All right. So I think we're going to take away our PowerPoint and just get into some questions. And so our very first question, and I'd like each of you to answer it. And we'll start in the order that we did our introductions, but can you describe your scope of practice? And we'll start with Brett.
Yeah, so the basics of street medicine is that people experiencing especially unsheltered homelessness can't access healthcare the way that people who are housed do. And so we go to them first to deliver an understanding love, and then the same quality of care on the street that you'd expect in a brick and mortar clinic. Our scope is full scope primary care and preventative medicine for this population, people who are unsheltered. That includes doing a very high level of behavioral health care, diagnosing and treating psychiatric conditions, doing long-acting injectable antipsychotics, being able to do MAT on the street, and treatment for all substance uses, all substance use disorders. And so we think of it as primary care plus.
Awesome. Thank you, Brett. Katie.
In my current role at California Bridge Connect, I'm the navigator for our hotline, which we will be releasing very shortly across California to connect folks to rapid, low barrier access to MAT. What that looks like for me is taking phone calls, seeing where people are at, getting them to the lowest barrier resource that we have possible in their area, or otherwise potentially connecting them to an online prescriber or someone who could talk to them over the phone. In addition to that, I'm connecting them to harm reduction resources such as syringe service programs, naloxone, really anything that the person calling me is looking for to stay safe or to stay healthy.
So thank you. Shai.
For me, I'm the chief of psychiatry over countywide engagement services. DMH, the Department of Mental Health, is the mental health plan for LA County, which means they're providing specialty mental health services. So the department broadly is serving the sickest of the sick, people with serious and persistent mental illness, severe impairments, people who are justice involved, experiencing homelessness, pretty comprehensive impairments. That's all of DMH. So we would consider that the safety net of the system. The division that I kind of am the chief of, the countywide engagement division, is the safety net of the safety net, taking care of folks who have completely disconnected from services. They're not benefiting from lower levels of care, even in DMH. They're ending up either in the forensic system, or they're languishing on the streets, or they're cycling rapidly between different inpatient hospitals or on the verge of conservatorship. That's the population that I kind of work with. And you can imagine working with that population, what kind of systemic resources you need to activate. Hint, it's all of them. But what this requires is street psychiatry, because you need a psychiatrist on the street working with these individuals, going into non-traditional settings and integrating system-wide resources, which includes treatment on the street, injections on the street, labs on the street, vitals on the street, coordination with the forensic system, coordination with ERs, inpatient units, involuntary hospitalization, conservatorship. It requires massive integration of services. So one of the things that is definitely impacting everyone is substance use. So we are frequently treating substance use disorders in addition to these complex care plans that we have to develop.
Awesome. Thank you. I'm going to turn it over to Rachel.
So many of the counties that are on today are at varying stages of standing up and launching this work, and really interested to hear from you all, as counties are approaching this and examining the structure that they are building or have built. What's at the beginning, what are some of the strategies that you all have used to kind of think about and approach initial outreach and engagement of the people we're hoping to connect with? And Katie, I'll go ahead and start with you this time, if you don't mind.
Yeah. Kind of speaking from the perspective of someone who's working in an emergency department for several years, we saw a lot of the patients that typically would use the ED for primary care or
Mhm.
who otherwise could not access preventative care. So looking at a lot of unhoused folks with substance use disorders or concurrent mental health and substance use disorders. Um, Strategies to consider for county behavioral health to engage with those populations, I would say very important to have the emergency department creating a continuum of care after the patient discharges. So if somebody is getting started, for example, on MAT in the emergency department, it's one thing for a doctor to provide 2 days worth of medication and say, good luck, you're on your own. It's another to involve a social worker or a substance use navigator to get them an appointment to continue their care, whether it's with a street medicine team or county or whatever resources available. Having a referral pathway from the emergency department into county services and into partner services, whether it's an FQHC or another provider, I think is really important when we're looking at trying to engage folks specifically from the ED.
That's great, Katie. Thank you so much. And so really thinking through that, what happens after that initial contact and making sure that that's followed through. I really appreciate that. Shai, if you don't mind me going to you next, what thoughts do you have on this question?
So at LA County, I think what we have, I lovingly call it developing psychiatry 2.0. And that is that the entire system needs to be on the exact same page for the people that I am serving. And part of that has meant creating structure in a structureless world. What are the best practices as people transition from one level of care to another? What is the best practice when someone is being released from jail to link them to the community? What is the best practice when someone is coming off an involuntary hold? How do you get someone linked to the community if they're unhoused? These are questions that there haven't really been many answers to, and we've been redefining how we approach this, at least at LA County DMH. One key element for us has been street psychiatry. For the first time, someone who is on the street unhoused, who needs these system-wide resources being activated, has a multidisciplinary team with a expertly trained psychiatrist who will facilitate recovery and stay connected to the individual as they move through these different levels of care. And that has been key. One team that supervises recovery across multiple levels of care. That is what it has taken to prevent drop-offs and fallout from happening as people receive, because you can't transform someone who's unhoused, chronically mentally ill, severely mentally ill with severe impairments and just transfer the care to someone else and hope that it'll work. You need to hold that person's hand and walk them through all the levels of care so they can reach true community reintegration where they're finding a safe place to live in the community, possibly reuniting with important people in their lives or family, and finding meaning and purpose in life. That is one singular team that has to kind of help with that journey of transformation. And we've been able to do that as a county in Los Angeles, which is very exciting to be a part of.
That's really great. So it's about flipping that model from trying to force other people to fit the model that we built, and then instead redesigning the model to fit the people that we're serving, it sounds like.
Oh, absolutely. If I
Yeah.
have a patient on the street and they come to your level of care, I will be there with them. I will be with them holding, joining the fight to see how I can help this person move along. And when they leave your doors, they're going to come back to my doors and I will help them get to where they're going. It's the idea of there being a shared vision for recovery.
Mhm.
And that can only happen if someone truly says, this is my client, I'm primary for this journey of recovery. And wherever it takes that, I will be with them. And it has to be truly multidisciplinary. I hate to say this, but physicians are at the top of many of the different levels of care, and having a physician-led team where you have this medically monitored supervision of recovery has been a huge effort and has been hugely responsible for home team success in this space. And I'll talk about what home team is, but it's essentially DMH's Delta Force for street psychiatry.
It's great. Thank you so much. Brett, how about you?
Yeah, I mean, for us, in street medicine, we always talk about building the system from the street backwards, which kind of gets back
Mhm.
to what you say. So often we are so system centric, we don't even realize when we're being system centric. And so when you look at people who are experiencing unsheltered homelessness, especially with SMI, which is the county's responsibility, um, they have really difficult time with just meeting their basic needs. For example, in LA, we know about 30% eat 4 or less meals a week. Nobody has access to a reliable shower. 85% are forced to open defecation. Getting water is hard. All these things are really hard, and even harder if you have SMI.
Hmm.
And many people who are unsheltered have SMI or significant substance use disorders. And so that's why, similar to what Shai was saying, when we go to the people, we have to be ready to provide full scope care. If you go without a prescriber, you're still relying on referrals to a brick and mortar clinic or somewhere else, which they're not going to be able to get to in the first place. And so for engagement strategies and how we're going to identify this population, where we started, and it's a great place for counties to start too, for the same reason, is we began understanding that we're a very limited resource. For street medicine at the time, I was the only employee of USC Street Medicine, and I had to answer the question, there's lots of people on the street, who's first? And rather than just starting geographically and fanning out with general outreach, we used hospital admission as a proxy for medical necessity, thinking if they were admitted for something, they would likely need follow-up for something. Um, and then as we grew our team, we then began to do more geographic outreach. But I know some of the counties on the call are not LA. It's much smaller. They're not going to be able to field multiple teams at a time because of resource constraints. So that might be a good way for them to start. Now we're bigger and we can start with general outreach, essentially going 10 to 10. Um, and that's a good engagement tool, again, for the counties on the call who might not be able to staff massive outreach efforts to partner with their friendly local street medicine programs and get referrals from them. Allow somebody else to do the outreach. They'll provide a certain level of behavioral health care. And when they need extra help, they need specialty mental health, then they can refer to you and be a quality referral.
Hmm.
That's great. Thank you. Charles, back to you.
Yeah, so this next question is kind of percolated up from our regional workshops, and I'm going to direct this to Shai. How does LA County manage medications for those who are unhoused? And you're on mute.
I'm very happy you asked that question because prescribing, everybody, you might think, oh, prescribing medications on the street, very simple. It is not a simple process at all. It is a it's dangerous potentially. It has to be done very, very safely. So I'm going to kind of back up a little bit and talk about how DMH has been providing medications to people who are unhoused in the street. Goes back to 2020 when I first joined the department's home team. Home stands for Homeless Outreach Mobile Engagement. What is home team? It's essentially a field-based multidisciplinary team, just like FSP. And the one thing that was unique about these positions is that they wanted, for the first time, a psychiatrist not to be field capable, but to be truly street based, where they're going out and meeting people where they're not waiting for people to be brought them to the clinic, but literally going out in the street and meeting people where they're at. I tried to Google what a street psychiatrist was when I first took this job, and I didn't get any hits. I tried going to the medical literature and asking, how do I treat someone on the street as a street psychiatrist? And it said, unable to comprehend what are you even asking me? So there was no guidance on this. It was a very new space. So and like Brett said, the streets will teach you. We had to build a model from scratch with a team of people who cared, a multidisciplinary team with outreach workers, community health workers, substance use counselors, nurses, and psychiatry working together to figure out what someone needs. And what I realized quickly is that nobody wants to see a psychiatrist right away. So we actually have an extensive period of outreach and engagement where we work with someone's resistance, build a bond with them, establish trust, and then loop in a psychiatrist down the road. Our psychiatrists, I have to be expertly trained on how to work with people who are unhoused. That's not education that's random, that's consistently given in medical school or in residency training, it hasn't caught up. We want physicians to go to the street and provide this treatment. That training is elective. It's not mandatory. You have to go seek that education and knowledge and truly try to go in this space. One of the things that we did on the home team is we actually set up psychiatry residency training rotations where people began coming to the street and learning how to do this work. When someone accepted medications, we don't just hand someone a prescription. We don't hand them a bottle. We actually send our prescriptions to one of our partnered pharmacies that put them in these pre-packaged bubble packs with the individual's name, name of the medication, what time they have to take it for each dose. That gets shipped to our medication rooms. They're put in our licensed medications rooms, and then we take out every single dose each day and we give it to the individual. And now just imagine what kind of distribution pipeline that requires to do it countywide. So at any point in time, we are hand delivering medications and making sure people are actually taking them and not losing them or giving them to somebody else. They're appropriately taking their medications. And then once they demonstrate sufficient stability and response and safety, we then give them a long-acting injection. And this could be regular psychiatric medication or medication for addiction treatment as well. We do both. We're getting vitals on the street. We're getting labs on the street. We're monitoring these medications. And then not only just treating them on the street, but also bringing all of the housing resources the Department of Mental Health has to this individual and helping them get off the street so they can continue their recovery in a safe and safely within the community. We don't stop there. There's a lot of people who refuse medications, who don't want medications, who are not safe for medications. What do you do for those individuals? Well, this is where Home Team Street Psychiatry said, you know what, we are going to integrate with the larger medical system and mental health system, build partnerships with emergency rooms, with inpatient units. So when someone reaches the point where they need to be hospitalized voluntarily or involuntarily, we will get that individual to the right level of care and not just hand out the case, continue following up in a hospital, in an ER to make sure they have a warm handoff for what needs need to be addressed to support community linkage. Once that person is stabilized and medications are on board, including MAT or detox or whatever they needed, we pick them up and then we take them to the identified housing, the discharge plan identified jointly with the hospital and continue recovery there. If that doesn't work, either for ongoing medications in the community, we will also pursue outpatient conservatorship, which is something that the home team can do. And as a last resort, when everything else fails, we will turn to the courts to help us get powers to treat people and still keep them in the community, not warehouse them in locked institutionalized settings, but to put them in community-based settings where we can make sure they are being treated. So it was a small question, but there is a very, very long answer. And now these innovations by the home team are moving into the rest of the department. So where it's almost like we are doing these innovations that are going to diffuse into the rest of Los Angeles County. And home team and what we do is become a leader. We've been in LA and the New York Times, LA in the LA Times, New York Times, CBS National News, and other counties are coming to us to learn from this model so they too can benefit from the innovations that we are making.
That's awesome. Thank you so much. Appreciate it. Rachel, back to you.
All right. And Brett, I'll start with you this time. As we know, and as you know, we're talking, as you mentioned, we're talking to counties of various size, various pools of resources. It's rare that teams are able to meet all of the needs of all the people they serve on their own. How are you all going about developing, identifying, and structuring strategic partnerships with other agencies to really meet the holistic needs of the whole person that you're serving?
Yeah. Well, I'll give you the ideal and then I'll give you what you end up doing. Is so the ideal, and we're trying to build this. Shai and I, we're working on this. The ideal is that everybody does what they're best at.
Mhm.
And we're best at primary care. Hopefully we'll find street-based primary care. Hopefully we'll find a good housing partner. Shai does street psychiatry great and specialty mental health. And it it would be it would be best if because he's only looking for people who are SMI, which is a segment of the
Mhm.
unsheltered population. So they don't want to spend all their time doing assessments for everybody, looking for that, smaller percentage that will qualify. And so the idea is that you're deploying primary care, street medicine, um, people, we can treat mild to moderate illness, which is a lot of people. And then if I need help, then I can refer to Shy. And then after Shy sees them, they'll get stable. Always happens, right, Shy?
Mhm.
And then once they're stable, they don't need to stay in county mental health. They can refer back down to us. So it creates an outlet valve. And the entire time, the motto is to go to the people and then go where they go, whether it's on the streets or in different housing settings. The whole time they keep the same primary care street medicine team. So even when Shy has them in county specialty care, I still see them as primary care. So that when they're ready to be um, transferred back down. There's not a warm handoff. We've
Mhm.
never left them. Um, what typically ends up happening is that no, nobody has enough resources. And there might be something of everything in the
Right.
county, but not enough of anything. And so in the absence of all those things being built, it's best if you try and do it yourself. The more handoffs you have, the more referrals you make, the less likely things are going
Yeah.
to work out. And so what Shai was describing is the same thing that we do. We dispense medications on the street. I bring out 60 or more medications a day with me on the street. We do point of care ultrasound, draw labs in the street. We even started doing housing just because I knew we could rely on it if we were doing it ourselves. Um, so don't wait and just let people suffer while you're waiting for the system to catch up. You might have to create it yourself.
I like that. And I appreciate what you say about it's not a warm handoff. We've been with them all along, because I think that is something that's very different about the approach that you all have described today. It's not a referral, see you later, hope it works out for you. It's a no, no, no. And as Shai said, nope, we'll be we'll actually be at the appointment with you if that's something that you're okay with. That's a very different experience, and that is has been such a gap for folks that we serve for so long. Katie, I would love to hear your response to the same question about how you're approaching these partnerships.
Yeah, kind of seconding what Brett said, I think there's a lot of opportunity for bidirectional
Mhm.
partnerships. So if the street medicine team that you're working with needs to pass someone along to a higher level of care, then there's an option there, there's an availability there to do so, and then passing them right back when things get better and they can go back to primary care. Um, I do want to talk about California Bridge Connect specifically and how it can help with identifying, developing, and structuring those partnerships for counties. We exist to integrate community touch points together and
Mhm.
making those relationships happen. We can serve as an on-ramp to treatment, and the BHSA funds that county receives can be used to support partnerships between California Bridge Connect and high-risk community touch points. Um, so utilizing California Bridge Connect is an option for counties as we start to launch, but identifying, developing, and structuring partnerships with other agencies. I love Brett's answer. It's finding who's working and who's doing the good work and who's doing it best and keeping patients and keeping community members in that care. Um, I don't think we need to be reinventing the wheel if someone is out there doing good work. And one way that you can find out who is doing this good work is going to the folks who are on the ground who are receiving this care, asking
Mhm.
them who comes to you every week, who do you see consistently, and who is helping you out the most. And then from there, learning who is providing the work on the ground. And you want to work with those people.
Thank you. Thank you so much. I think that really, really great. Charles, back to you.
Yeah, okay. Let's start with Katie again. Katie, and then I'll go to Brett. I'm interested in knowing how can field-based team members approach motivational enhancement for individuals who've not yet had recent capacity to prioritize their own self-care.
Mm.
I want to pick on the word self-care a little bit because I think for some people, self-care is, getting enough sleep every night and taking a hot bath when your muscles hurt. And, just we think of self-care a certain way, but for folks who are severely under-resourced, who are experiencing unsheltered homelessness, self-care can look completely different and could even not align with their health goals. An example is folks will use substances to stay awake through the night so that way their safety is preserved. Or others may engage in high risk sexual behaviors in order to ensure that they have housing for the night. And that's self-care. As much as it may not be seen by someone outside of this world as self-care, that is self-care because it's preserving their safety and their security in the short term that they need it for that moment. So when we're thinking about self-care and trying to do motivational enhancement for folks who otherwise couldn't prioritize it, I want to give a shout out to things like contingency management, because for folks who don't know, it's essentially providing negative drug screenings or otherwise proving that you are reducing or stopping your typically stimulant use. And in exchange for those negative drug tests, you receive some kind of incentive, whether that's like a gift card or a grocery card or cash, or there's different models. But that cash, that reward is a basic need that you're providing to that person. And providing basic needs such as gift cards or cash to people as a reward for prioritizing their health is kind of changing self-care to be more reflective of, hey, I also want to focus on my health goals too. So self-care, it's a lot to try to expect somebody who is in dire circumstances where survival is every single day something that's on their mind. It's hard to tell them, oh, you should engage in some self-care, when the reality is we need to be able to provide that for them. We need to give avenues for them to prioritize self-care.
Yeah, thank you. Brett, anything you want to add to the mix?
Yeah, and I agree with Katie about the self-care that sometimes that first use of their substance of choice in the morning keeps them from getting sick, and that's how they take care of themselves to make it through the day. But it's usually not comfortable. Like what I've found is that people who have a substance use disorder or a mental health disorder, there's usually something uncomfortable about it for them. Like they don't want to have to find that drug right away in the morning. Um, if they're telling me they're depressed or anxious, that's probably not comfortable. If they have like auditory or visual hallucinations, is that bothering them? Do they want somebody telling them what a terrible person they are? Do they want to see demons? Usually these are very uncomfortable for them. And that's where the motivation comes in. Like, okay, these are uncomfortable for you. There are things we can do to make it easier, and to ease some of that discomfort. And that's usually where I'll start.
Nice. Okay, thank you very much. I'm going to turn it over to Meyer, and we've got some final slides for you all.
Thank you so much for viewing today's webinar. If you have any questions at all, please email us at info@afbsstraining.org. Have a wonderful day.